Questions about your genes or your DNA, let's find the answers. Ask a genetic counselor.
Hello, everyone, and welcome back to Ask a Genetic Counselor, the podcast where your genetics questions shape the conversation. I'm your host, licensed genetic counselor, Sam Geere. And as always, today's episode is based on questions that you've submitted. So feel free to leave any questions you want me to address in the comments section of these podcasts. And remember, there's no question off limits. So without further ado, let's jump into the first question. All right, so our first question says, for the next episode, could you explain double-jointedness and any connection to genetic conditions? So first of all, thank you so much for submitting this question because it opens the door to talking about something that affects a surprising number of people. Now, the term double-jointed has been around for a long time, and almost everyone knows someone who describes themselves that way. Maybe it's someone who can bend their thumb all the way back to their forearm. Maybe they can straighten their elbow farther than everyone else. Maybe they can place both palms flat on the floor without bending their knees. We've all probably known someone like that. But despite the name, those people don't actually have an extra joint. So they don't have two elbows or two thumb joints or extra knees. Instead, what they're actually describing is something called joint hypermobility. Let's break that word apart because I think it makes it much easier to understand. Hyper simply means more than usual, and mobility refers to movement. So hypermobility literally means more movement than expected. In other words, the joint moves beyond the range that we typically see in most people. So instead of thinking about someone having an extra joint, it's more accurate to think of the same joint simply having a larger range of motion. Now, that naturally leads to another question. Why? Why are some people's joints able to move so much farther than everyone else's? And the answer has a lot to do with something called connective tissue. When most people think about the body, they're thinking about organs like the heart, lungs, liver, you name it. But connective tissue isn't really one organ. It's more like the material that helps support all of those organs. I like to think of it this way. Imagine you're looking at a suspension bridge. Most people notice the roadway, the cars driving across it, the towers, but what's actually keeping the bridge standing is the steel cables, the bolts, the framework, the support structures holding everything together. Without those, the bridge simply wouldn't function. Connective tissue is similar. It's part of the body's support system, and it helps provide strength, structure, flexibility, and stability. Connective tissue is found in your skin, ligaments, tendons, blood vessels, and so many other places throughout your body. So, in other words, it's everywhere. And one of the major proteins that gives to connective tissue its strength is collagen. So, you've probably heard collagen talked about in skincare commercials or advertisements for supplements, but collagen isn't just about wrinkles. It's actually one of the most abundant proteins in the human body. Think of it as one of the body's primary building materials. It's helping tissues stay strong while still allowing them to be flexible. Now imagine that the ligaments around a joint are just a little more flexible than average. That joint may naturally move farther than someone else's. That's hypermobility. And here's the really important point. Hypermobility by itself is not necessarily a disease. I really want to emphasize that because I think it's where social media sometimes creates unnecessary fear. There are plenty of completely healthy people who are naturally more flexible than average. In fact, joint flexibility exists on a spectrum. Some people are naturally very stiff, some fall in between, and some are naturally quite flexible. But none of those are automatically abnormal. You've probably seen this yourself. Gymnasts, dancers, figure skaters, many of them can move their joints through an incredible range of motion. Now, some of that does come from training, but some people are simply born more flexible than others. Children also tend to be more flexible than adults. As we get older, our connective tissues gradually become a little less flexible, so it's common for hypermobility to decrease over time. Women also tend to be more flexible than men on average, and researchers have found differences across populations. So if you're sitting there thinking, wait, I've always been able to bend my thumb back, or I've always been flexible, that alone doesn't mean something is wrong. With that in mind, how do we decide whether someone's flexibility is simply a normal variation or whether it's part of something bigger? One of the tools healthcare providers sometimes use is something called the Beighton score. Now, before anyone listening starts trying to diagnose themselves, I want to explain what this score is, and maybe even more importantly, what it isn't. The Beighton score is simply a screening tool. It's a quick way to assess whether someone has generalized joint hypermobility. It's not a diagnosis. So think of it like taking someone's temperature. If someone has a fever, that tells us something's going on. But the fever itself doesn't tell us whether they have the flu, strep throat, COVID, or something entirely different. It's a clue. The Beighton score works in a similar way. Healthcare providers look at several joints throughout the body and see whether they move beyond what's considered a typical range. For example, they might look to see whether your little finger bends back beyond 90 degrees, whether your thumb can touch your forearm, whether your elbows or knees extend beyond that we expect, or whether you can place your palms flat on the floor without bending your knees. Each of those movements contributes to the overall score. But here's something that's really important. The Beighton score isn't interpreted exactly the same way for everyone. Age matters, children are generally more flexible than adults. Sex matters, and someone's history matters too. Maybe someone was very flexible when they were younger, but has become less flexible over time. That history is still valuable. So even though the Beighton score is commonly discussed online, it's only one piece of a much larger evaluation. Because at the end of the day, a score doesn't tell the whole story. A person does. All right, let's move on to our next question. Question 2 states, my doctor told me I'm hypermobile, but I don't have Ehlers-Danlos syndrome. What's the difference? This is such a great question because I think this is where a lot of confusion comes in. Someone goes to their doctor because they're having joint pain. Maybe they've had a few dislocations, or perhaps they're just naturally very flexible. They get evaluated and they're told, yes, you're hypermobile. Then naturally, that person goes home, types hypermobility into Google, and suddenly they're reading about Ehlers-Danlos syndrome. And so maybe they think, wait a minute, if I'm hypermobile, doesn't that mean I have Ehlers-Danlos? And the answer is not necessarily. The easiest way to think about it is this. Hypermobility is a finding. Ehlers-Danlos syndrome is a diagnosis. Hypermobility simply describes the fact that someone's joints move farther than we typically expect. It doesn't automatically tell us why, though. Now, for many people, there isn't a disease causing it at all. Some people are simply naturally more flexible than average. But on the other hand, some people are hypermobile and experience symptoms because of that increased flexibility. Those individuals may fall into a category called hypermobility spectrum disorders, or HSD for short. Now, HSD is something I think deserves more attention because people don't talk about it very often. Sometimes people hear, you don't have Ehlers-Danlos syndrome, and what they hear is, nothing is wrong. Those are not the same statement. Someone with HSD can absolutely have real symptoms that deserve evaluation and treatment. Then we have another group of individuals who are hypermobile and meet additional diagnostic criteria for hypermobile Ehlers-Danlos syndrome, or HEDS. Now, when we say Ehlers-Danlos syndrome, we're actually talking about a group of conditions. There isn't just one type. There are multiple subtypes, each with its own genetic cause, clinical features, and inheritance pattern. The hypermobile type is simply the one most people have heard about because it's the most common. Other forms like classical Ehlers-Danlos syndrome or vascular Ehlers-Danlos syndrome have different features and different genetic causes. That's one reason genetics can play such an important role in evaluating someone with suspected connective tissue disease. Sometimes the evaluation isn't just asking, does this person have EDS? It's asking if they do have an inherited connective tissue disorder, which one best explains everything we're seeing? Because there are several conditions that can overlap, like Marfan or Loeys-Dietz syndrome, and certain forms of osteogenesis imperfecta. Some of these conditions share features like joint hypermobility, but they can also have important differences that affect medical management and screening. That's why getting the diagnosis right matters. Now, another question I hear fairly often is if hypermobile Ehlers-Danlos syndrome is genetic, why didn't my doctor just order a genetic test? And I completely understand why people ask that. It seems logical. Genetic condition, genetic test, right? But this is actually one of the most interesting areas of medical genetics because sometimes biology is more complicated than we expect. When most people think about genetic testing, they imagine that there's one gene for one condition. If you have the condition, we test the gene. If the test is positive, we have our answer. And while that certainly is true for many genetic conditions, it isn't true for all of them. Remember earlier when I mentioned that Ehlers-Danlos syndrome is actually a group of disorders? For many of those subtypes, we do know the genetic cause. For example, classical Ehlers-Danlos syndrome is often caused by changes in genes like COL5A1 or COL5A2, which are involved in making type 5 collagen. Vascular EDS is most commonly associated with changes in a gene called COL3A1, which helps make type 3 collagen. And because we've identified those genes, genetic testing can often help confirm those diagnoses with clinical picture fits. But hypermobile Ehlers-Danlos syndrome is different. Despite being the most common subtype of Ehlers-Danlos, researchers have not yet identified a single genetic cause that explains most people with HEDS. There are still genes being discovered, new disease mechanisms being identified, new connections being made. So when someone asks, why isn't there a genetic test for HEDS? The answer isn't because it isn't genetic. The answer is because we haven't fully figured out the genetics yet. We know hypermobile EDS tends to run in families. We know it often follows what looks like an autosomal dominant inheritance pattern, meaning it can be passed from one generation to the next. We just don't have one genetic test that can explain most cases yet. And that's one of the reasons genetics can sometimes be humbling. Even as genetic counselors, we have to be comfortable saying, we don't know yet. Science is always moving forward, and sometimes we have the answer, but other times we're still searching for it. And both of those are okay. So if there isn't a genetic test, how is HEDS diagnosed? This is where medicine becomes a little bit like detective work. Instead of relying on a laboratory test, healthcare providers put together many different pieces of information. They look at the person's medical history, physical examination, whether they have generalized joint hypermobility, and other findings. Importantly, they also ask whether another diagnosis could better explain what they're seeing. So, in other words, they're building a puzzle. So, while there isn't currently a genetic test that confirms HEDS, genetics still plays a very important role in the evaluation. It's helping answer a slightly different question. Is there another inherited connective tissue disorder that better explains what we're seeing? And I think that's an important distinction because sometimes people hear your genetic testing was negative and they assume that means nothing's wrong. But that's not necessarily what a negative result means. It simply means we didn't find a disease causing change in the genes we currently know how to test. As our understanding of genetics continues to grow, that may change in the future. That's why you'll sometimes hear about people being reevaluated years later as new discoveries are made. So, if you're someone who's wondering whether you might have hypermobile EDS, this is a great example of why working with healthcare providers who are familiar with connective tissue disorders can be so valuable. Because a diagnosis isn't based on just one symptom, and it isn't based on one laboratory test. It's based on the entire clinical picture. And this brings us to our next question. Question 3 states, I've had symptoms for years and have seen so many different specialists. Why can connective tissue disorders take so long to diagnose? This is an important question and one that I hear commonly. When you've been searching for answers for years, it's completely understandable to wonder, why didn't anyone put all of this together sooner? And before I say anything else, I want to start here. A long diagnostic journey doesn't mean your symptoms aren't real. And it doesn't necessarily mean that your doctors weren't listening. Sometimes it means you've been trying to solve a puzzle where all of the pieces didn't become visible at the same time. One of the biggest challenges with connective tissue disorders is that they rarely announce themselves all at once. Instead, they tend to unfold over time. Maybe as a child, you were just known as the kid who could do the splits without trying. Or maybe you were constantly spraining your ankles, but everyone assumed you were just clumsy or active. Years later, your joints become more painful, maybe your shoulders start slipping out of place, then you begin having digestive systems or dizziness when you stand, or chronic fatigue. Looking back, it can feel like all of those things were connected from the very beginning. But when you're living through them, they often don't happen all at once. They happen one chapter at a time, and medicine often works the same way. Healthcare providers don't get to read the whole book on the first visit. They're seeing one chapter, one symptom, one moment in time. If you see an orthopedic surgeon because your shoulder keeps dislocating, they're going to think carefully about your shoulder. If you see a gastroenterologist because you've had years of abdominal pain, they're going to focus on your digestive system. If you see a cardiologist because you've been having palpitations or dizziness, they're going to evaluate your heart and blood vessels. And that's exactly what we want them to do. Each specialist brings a tremendous amount of expertise to one area of the body. The challenge is that connective tissue doesn't belong to just one area of the body. It touches many of them. So sometimes each specialist is holding one piece of the puzzle without anyone yet seeing the picture on the box. That's where genetics can sometimes provide a different perspective. One of my favorite parts of being a genetic counselor is getting to hear someone's entire story, not just the symptom that brought them in that day, the whole story. When did everything start? What came first? What changed over time? Has anyone else in the family experienced something similar? What evaluations have already been done? Sometimes people apologize because they feel like they're telling me too much information. They'll say, "I'm sorry, this probably isn't relevant." And honestly, those moments always make me smile a little. Because in genetics, sometimes the detail someone almost leaves out ends up being incredibly helpful. Maybe they casually mention that their mom has always had unusually flexible fingers, or that an uncle needed surgery for an aneurysm, or that everyone in the family jokes about having bad ankles. Does that automatically mean there's a genetic condition? No, absolutely not. But it does give me more context, and genetics is a field that depends on context. One thing I've learned over the years is that patients often think I'm looking for one dramatic clue, the one symptom that's going to suddenly reveal the diagnosis. Most of the time, that's not what happens. It's usually much quieter than that. It's dozens of little pieces that by themselves don't seem particularly unusual, but together, they tell a story. And that's really what a genetics evaluation is. It's storytelling through medicine. We're taking a lifetime of medical history, family history, physical findings, and trying to understand whether those pieces fit together in a way that suggests an underlying genetic condition. Sometimes they do, sometimes they don't. And both outcomes are valuable. Because just as important as identifying a connective tissue disorder is, recognizing when another explanation fits better also is. One thing I also want people to know is that medicine isn't static. Our understanding of connective tissue disorders has changed tremendously over the last several decades. We're recognizing these conditions more often, we're learning more about them, diagnostic criteria continue to evolve, and researchers continue searching for new genetic causes. That's encouraging. But it also means that some people who spent years without answers may finally be evaluated today in a way that simply wasn't possible 15 or 20 years ago. And I think that's worth remembering. Finally, I want to say something to anyone listening who may still be in the middle of that journey. It's okay to want answers, it's okay to advocate for yourself, and it's okay to ask questions. It's also important to let the process unfold. The goal is to find the diagnosis or diagnoses that most accurately explain what's going on. Sometimes that's a connective tissue disorder. Sometimes it's something completely different. And sometimes it takes time before the picture becomes clear. That uncertainty can be frustrating, and I completely understand. Know that uncertainty doesn't mean there isn't an answer. Sometimes it simply means you're still gathering those pieces. And as a genetic counselor, that's really what I hope people take away from today's conversation. Genetics isn't about finding one symptom that explains everything. It's about listening carefully enough to understand the entire story. Now let's move on to question 4. Question 4 asks, I finally got a diagnosis. Now what? I really like this question because I think it's one that doesn't get talked about enough. We spend so much time focusing on getting to a diagnosis. We talk about finding the right specialist, getting the right testing, waiting for appointments, waiting for results, and it's easy to think that diagnosis is the finish line. Like once someone finally gives your condition a name, everything's going to fall into place. And while a diagnosis can absolutely be a huge moment, and for many people it often isn't the end of the journey. In many ways, it's the beginning of a different one. I've talked to many people over the years who describe finally getting a diagnosis as both a relief and an emotional adjustment at the same time. On one hand, there's relief. Maybe you've spent years wondering if the symptoms were connected. Maybe you've been told that each symptom was unrelated. Maybe you've seen multiple specialists. Maybe you've questioned yourself. So finally having an explanation can feel incredibly validating. It can be the first time someone says, there's actually a reason these things have been happening. For many people, that alone brings a tremendous sense of relief. But then something interesting happens. Once that initial relief settles, a new set of questions often appear. Okay, now what? What does this mean for the rest of my life? What should I actually do? Does this change anything? And I think those are incredibly reasonable questions. Because a diagnosis by itself doesn't automatically tell you how to move forward. It gives you information, and then the next step is figuring out how to use that information. One thing I always try to remind people is that not every diagnosis changes your life overnight. Sometimes it changes the way we think about symptoms that have already been there for years. For example, maybe someone has always modified certain activities because they knew their joints were unstable. Maybe they've already found that physical therapy has been helpful. Maybe they've already developed strategies that work well for their body. Receiving the diagnosis doesn't suddenly erase everything they've learned about themselves. Instead, it helps explain why those strategies have been so helpful. It provides context. And I think that's an important distinction. A diagnosis doesn't change who you are, it helps you better understand who you've been all along. Now, from a genetics perspective, one of the reasons getting the diagnosis right matters is because it can influence medical management. Not every connective tissue disorder is managed the same way. Different conditions can have different recommendations for surveillance, different specialists who may become involved, and different health considerations over a person's lifetime. For example, someone with one connective tissue disorder may benefit from periodic cardiovascular imaging, while another person may not have the same recommendations. Someone else may be referred to ophthalmology because eye findings are an important part of their condition. Another person may work closely with physical therapy to improve joint stability and reduce injuries. The management really depends on the diagnosis. And that's why we spend so much time trying to make sure we're calling something by the correct name. It's not about collecting labels, it's about making sure people receive the care that's most appropriate for their condition. Another thing that often changes after a diagnosis is the conversation about family history. One of the first questions many people ask is, what does this mean for my family? And that's a question genetic counselors spend a lot of time discussing. Is this something that could have been inherited? If so, what does that inheritance pattern look like? Should other relatives consider an evaluation? Would genetic testing be helpful for anyone else in the family? If someone is thinking about having children in the future, are there reproductive considerations they should know about? Those conversations are different for every condition and every family. There isn't one answer that fits everyone. but understanding the diagnosis helps guide those discussions. I also think it's important to acknowledge that receiving a diagnosis can affect people emotionally in very different ways. Some people feel relieved, while others feel overwhelmed. Some people feel sad. Some people feel angry that it took so long. Some people feel validated. And honestly, many people feel several of those emotions at the same time. There isn't a correct way to respond. I've met people who wanted to read every research article they could find the day they were diagnosed. I've also met people who needed to step away from Google for a while because they were already emotionally exhausted. Both approaches are understandable. One piece of advice I often give people is to remember that the internet tends to amplify extremes. People who are doing well often aren't posting online because they're out living their lives. The people you find in support groups are often the ones looking for answers during particularly difficult moments. Those communities can be so supportive, and many people find comfort in connecting with others who understand what they're experiencing. It's also important to remember that another person's experience isn't necessarily going to be your experience. Even with the same diagnosis, symptoms can vary from one individual to another. We've actually talked about that idea before on this podcast. Genetics often influences risk, but it doesn't always predict exactly how a condition will affect a particular person. So while learning from others can be helpful, try not to assume your future has already been written by someone else's story. Another thing I encourage people to do is to think about building a healthcare team, rather than searching for one doctor who has every answer. Connective tissue disorders often involve multiple body systems. That means your care may involve your primary care provider, specialists depending on your symptoms, physical therapists, and in some cases, genetics. No one healthcare provider is expected to manage every aspect of every connective tissue disorder. Good care is often collaborative. And I actually think that's reassuring because it means you don't have to navigate everything alone. Lastly, I want to say something that I think is easy to lose sight of after receiving any medical diagnosis. You're still the same person you were the day before you received the diagnosis. The diagnosis didn't create your resilience. It didn't create your strengths. It didn't suddenly define your identity. It simply gave a name to something that was already part of your story. And while names matter, they help guide medical care, they help explain what's happening, and they help connect people with appropriate resources. They don't tell the whole story of who someone is. I've always believed one of the most important things genetics can offer isn't certainty, it's understanding. Sometimes that understanding comes through a genetic test, sometimes it comes through a clinical diagnosis, sometimes through finally having someone look at the entire picture and say, I think I understand what's been happening. And if you've recently received a diagnosis, I hope you give yourself permission to take things one step at a time. You don't have to become an expert overnight. You don't have to have every question answered immediately. It's okay to learn as you go. Ask questions, find healthcare providers you trust, seek out reliable information, connect with others if that feels helpful, and remember that receiving a diagnosis isn't the end of your story. For many, it's simply the beginning of understanding it a little better. Now let's take a look at our last question. Question 5 states, what surprises people most when they come to a genetics appointment? I love this question because I think most people have a different idea in their head of what a genetics appointment is going to be like. And then they come in, and it's usually pretty different than what they expected. One of the biggest surprises I notice is actually how much talking there is. That seems to be a surprise to many people. They often walk into the appointment expecting that we're immediately going to order you a genetic test. But in reality, one of the first things I usually ask is, tell me what's been going on. And then I listen, sometimes for quite a while. Because before we ever talk about testing, I want to understand why we're even considering testing in the first place. What symptoms have you experienced? When did they start? Have they changed over time? Have you seen other specialists? What's already been ruled out? Those details matter. And sometimes they matter much more than people realize. I think another thing that surprises people is how many questions we ask that don't seem related to the reason they came in. Someone might come in because they're concerned about joint hypermobility, and then I'll ask about eye problems. And sometimes people stop me and ask, wait a minute, why are you asking me about that? And I always mention the same thing. I'm not just trying to understand one symptom, I'm trying to understand you. Genetics is one of the few areas of medicine where what happened to your aunt or your grandfather or even someone in your family you've never met might help explain what's happening today. And that's pretty unique. I also think people are surprised by how much time we spend talking about family history. Sometimes they'll even apologize because they don't know every detail, or they'll say, I'm not very close with that side of the family, or I don't really know what my grandparents died from. And no, that's completely okay. Family histories are almost never perfect. And honestly, most people don't come into an appointment with a beautifully organized family tree and a complete medical record for every relative. We work with the information we have. Sometimes that information is incredibly detailed. Sometimes it's very limited, and both are okay. One thing I think surprises people is that we're often just as interested in what didn't happen as what did. For example, someone might say, no one else in my family has ever had this. That's important. Or maybe they'll tell me that 3 generations of relatives lived into their 90s without ever having an aneurysm. That's important too. Sometimes the absence of a family history is just as informative as it is the presence. Another thing people don't always expect is that we spend a lot of time talking about uncertainty. And I know uncertainty isn't anyone's favorite topic. We all like definitive answers, and I know I certainly do. Oh, a positive, negative, yes or no. But genetics doesn't always fit neatly into those boxes. Sometimes we find an answer, sometimes we rule conditions out, sometimes we narrow the possibilities. And sometimes we leave an appointment saying, here's what we know today, and here's what we still don't know. And I know that can feel a bit frustrating, but I actually think there's something reassuring about being honest about uncertainty. Because pretending we know more than we do doesn't help anyone. One of the things I love about genetics is that it's constantly evolving. There are conditions we understand today that we didn't understand 10 years ago. There are genes we're discovering today that we couldn't test for 20 years ago. There are families who finally receive an answer because research has caught up to what medicine couldn't explain before. And I think that's pretty cool. I also think people are surprised that genetics appointments aren't just about science. Of course, we talk about genes, we talk about inheritance, about genetic testing, but we also spend a lot of time talking about people, how a diagnosis might affect someone's family, how they're coping with uncertainty, what questions they still have, what they're hoping to get out of the appointment. Because at the end of the day, genetics isn't just about DNA. It's about people trying to make sense of something that's happening in their lives. And every person comes to that conversation from a different place. Some people are excited to learn everything they possibly can, while other people are terrified. Some people have been searching for answers for years. Others were completely blindsided by a diagnosis they weren't expecting. There isn't one right way to feel. I think another misconception is that people assume genetic counselors are there to tell them what decision to make. That's actually one of the biggest differences between genetic counseling and many other areas of healthcare. Our job isn't to make decisions for people. It's to make sure they understand their options well enough to make the decision that's right for them. Sometimes that's deciding whether or not to pursue genetic testing. Sometimes it's deciding whether to share information with family members. Sometimes it's deciding what information they even want to know. Those are incredibly personal decisions, and they're not the same for every individual or every family. I think the biggest surprise, and honestly my favorite part of this profession, is that people often leave saying, I finally understand what's been happening. Now, sometimes that's because we found a diagnosis. Sometimes it's because we ruled one out. Sometimes it's because we were able to explain why testing was or wasn't recommended. But regardless of the outcome, Understanding has value. I've always believed that one of the most powerful things you can give someone isn't necessarily an answer, it's clarity. It's taking something that has felt confusing, overwhelming, or frightening and making it feel understandable. And that's honestly one of the reasons I started All Things GC and this podcast. Whether it's through these podcast episodes, my YouTube videos, or sitting across from someone in clinic, my goal has always been the same: to help people understand genetics a little better than they did before. Because genetics can feel intimidating. It can feel like a completely different language, but it doesn't have to. And if these conversations help even one person feel a little more informed, a little less overwhelmed, or a little more confident asking questions about their own health, then I think they're worth having. And this brings us to the end of our episode for today. Thank you all so much for continuing to send in such thoughtful questions. They're what make this podcast possible, and I genuinely enjoy getting to sit down and explore them with you. So if you enjoyed today's episode, consider subscribing, leaving a comment, and sharing the podcast with someone who might find it helpful. So thank you again for being here, and until next time, keep asking those questions and keep staying curious. I'll see you in the next episode of Ask a Genetic Counselor.
Got questions about your genes or your DNA? Let's find the answers. Ask a genetic counselor.